Good morning, everyone. My name is Atif Bhatti, and I'm a volunteer here at Epilepsy Foundation, Washington. Our next speaker will be Dr. Andrew Ko. Dr. Ko is head of the UW Medicine Functional and Restorative Neurosurgery Program and a neurosurgeon with the Regional Epilepsy Center at Harborview Medical Center and a UW Assistant Professor of Neurological Surgery. Dr. Ko specializes in general neurosurgery, functional and restorative neurosurgery, epilepsy, and neurosurgery for pain. Dr. Ko earned his MD from University of Illinois, Chicago. His clinical interests include image-guided deep brain stimulation, open and stereotactic, minimally invasive surgery for epilepsy, and functional mapping of the brain and surgery for brain tumors. His research interests include deep brain stimulation, functional neurosurgery, epilepsy, and pain. Please welcome Dr. Ko.
So I'm going to talk about stereotactic surgery for epilepsy, and the reason I call it stereotactic is just most of these neuromodulatory therapies involve precise placement of electrodes, and DBS as well is a stereotactic surgery. The other subset of surgeries I'm going to talk about is laser ablation, which is a more minimally invasive way to do a resective, potentially curative type of neurosurgery. And that also involves stereotaxy. So all that really means is just we don't look where we're aiming directly. So it's not an open surgery where you're doing a craniotomy, taking off bone, resecting brain. These are procedures where generally you have a very small entry point, and you use computer navigation to be precise about where you put electrodes or the laser catheter. A brief overview of the talk. This data that I'm going to talk about is all in adults, and I know we're at children's, so we'll have to take everything I say with a grain of salt. I'm going to start talking just a little bit about surgery for epilepsy in general, and then laser ablation in particular for epilepsy, RNS, which is responsive neurostimulation for epilepsy, and DBS for epilepsy. So a few words, and again, this is not going to be a surprise to anybody in the audience, but epilepsy is not uncommon. The incidence is about 48 per 100,000, so about 150,000 new cases per year in the U.S. Your lifetime odds of developing epilepsy is about 1 in 26, and right now about 2.5 million people in the U.S. are affected. The first-line treatment is always medication. What that is in particular depends on the seizure syndrome. For most people, one drug works, or actually about half people exactly one drug works. Adding a second drug or trying different therapies, you get successful seizure control in about 15% additional of patients. After 2 good trials, the odds of finding something that makes you seizure-free for an extended period of time is around 5%. And that's not really changed much in the last 20 years despite new drugs. There's sort of 4 ways people tend to respond. So one is you start a drug and it works. The second is it takes a little bit. The third is you kind of go up and down. You have a honeymoon period where it seems to work and then it goes away. That benefit goes away. And then some unlucky folks just have no response to any of the medications. So again, if you fall into group 3 or 4, you're generally talking about a very low chance of seizure freedom over the years. And that's why we talk about epilepsy for surgery for epilepsy. Just one particular part of epilepsy, temporal lobe epilepsy, there is class 1 evidence that surgery is better than trying additional drugs. Amongst several trials for this rate of seizure freedom after a temporal lobectomy is about 60 to 65%. That could be with or without additional medications. And again, that's compared to 5 to 10% for just medical management. In terms of surgery for epilepsy that doesn't come from the temporal lobe, there's less data on it. It's just generally less common. But some of the things that can be associated with this would be focal cortical dysplasias, tumors, vascular malformations like cavernomas, and then some congenital problems such as tubers or heterotopias. We also do see folks that we, at this point, call non-lesional, meaning we don't see an abnormality on MRI or other imaging. Generally for these people, if you can localize their epilepsy, surgery is still an option, but the success rates are a bit lower. And again, these are a bit rare, so we don't have as good data on how people do. Just in terms of seizure outcomes, we have sort of 2 classifications that we use, the Engel classification or the International League Against Epilepsy. But basically, good outcomes for surgery we consider class 1 for the Engel classification are class 1 and 2 for the ILE, AE. But basically, we're looking at no disabling seizures is what we consider a success. So that's 60 to 65%. That's what we're talking about. Just one thing I always bring up is that this temporal lobe epilepsy study came out in 2001. So it's a randomized control trial, meaning the best evidence that we can get in medicine. And as soon as the trial came out, the number of surgeries dropped. They kind of have crept up, but it's interesting. There were more hospitalizations for epilepsy, but fewer surgeries, and it's just a funny coincidence, I think, but it's something to think about in terms of considering surgery. It does tend to put people off, but part of why I think some of the information in this talk is helpful is that there are other ways to try and get similar results that may be less invasive. So a little bit about the history of surgery for epilepsy. The history of neurosurgery and epilepsy are pretty closely tied together. Some of the first brain surgeries that were successful were done in England in the late 1800s. Victor Horsley and Hugh Jackson, his neurologist, did surgery for what we call Jacksonian epilepsy, so focal motor seizures. And what they do is a craniotomy, so they would take a piece of skull off, carefully map the brain underneath, look for the parts of the brain that move the arm and were involved with these motor seizures, and then take that part of the brain out, which would cure the epilepsy, but then you wouldn't move your arm. So a bit of a Pyrrhic victory. But if you think back to the 1800s, there were no medications for that, for treating epilepsy, really nothing until the 1940s. So this was actually not an unreasonable approach, I think. But what was interesting about this is mainly that this is sort of the pioneering for the use of electrical mapping for function and surgery under local anesthetic where the patient was participating in the surgery. In the 40s and 50s, Wilder Penfield and his neurologist Jaspers at the Montreal Neurological Institute started to do sort of combine EEG with surgical treatment of epilepsy. This combination of using neurophysiology with epilepsy let them establish this relationship between seizures and mesial temporal structures, so parts of the brain that tend to be epileptogenic. And this basically made it less of a guessing game in terms of, hey, if we take this part of the brain out, are you going to be seizure-free? Here's just a couple of other sort of momentous occasions. So there's different types of surgeries that you can do to address these temporal lobe epilepsy, temporal lobe seizures. So in the 50s, a sort of less invasive approach was described by Niemeyer. In the 60s, Talairach, a French anatomist, devised a way to use X-rays to be able to very precisely place electrodes in the brain to read brain signals. And we use some of these techniques now for DBS and for RNS. In the 60s and 70s, language mapping and long-term monitoring with EEG electrodes inside the skull were developed and popularized. And then here at the University of Washington, George Ogerman and, well, maybe it's just him, but his group did a lot of work on language mapping and localizing function within the cortex, again, using electrical stimulation and recording activity of the brain itself to let us get a better sense of what we could do without causing permanent harm when we're doing these types of surgeries. So in general, prior to thinking about surgery for epilepsy, there's steps that people go through for workup. Video EEG is something that's very common, and basically what this is connecting electrodes to the scalp and watching and waiting for seizures while obtaining video. This allows you to capture the behavior during a seizure, look at the brain activity during a seizure, coordinate the two, and it can often be helpful for at least trying to figure out if seizures coming from one side or a particular location on that side. Imaging plays a greater and greater role. So as we develop better MRIs, fMRI, PET scans, SPECT scans, these are basically pictures of the brain, usually, unfortunately, just moments in time. But if you do see a structural abnormality or some other indication that a part of the brain is not working correctly, this can be very useful. All of our surgical candidates get neuropsychological testing. Different parts of the brain can be affected by seizures over time, and if people develop cognitive deficits, usually we're looking at memory that can help us tell if seizures are more likely to be right or left-sided. It also gives us a baseline for after we do some of these interventions. We are taking brain out a lot of the time, or if we're placing a stimulator, it's good to see if we're affecting cognition and how people function. And this gives us a baseline measurement. And the last sort of group of tools in our toolbox is something called invasive monitoring. So scalp EEG is great because you can put leads on and pull them off, and I guess you might lose some hair, but otherwise it's not too invasive. But that does have limitations in what kind of resolution you can get, and so sometimes it's even hard to tell left or right for where seizures are coming from, and this may necessitate something called invasive monitoring, where we're implanting electrodes inside the brain or on top of the brain. And again, we do the long-term monitoring with those electrodes in place. So these are all tools that we use to decide whether or not somebody's appropriate for surgery, whether or not something like a resection is a goal where we can potentially get somebody seizure-free, or whether or not some of these other what we consider palliative therapies might be more appropriate. Just a quick word on mesial temporal sclerosis, which is a particular type of brain abnormality that we often see with temporal lobe epilepsy. And basically it's scarring within the hippocampus. And in general, it's always sort of a mixed bag when you see this, because on one hand it's good because your chances of being seizure-free are higher. On the other hand, it means your epilepsy is bad enough that it's caused a part of your brain to scar and not work right. So that said, this is something that we definitely look for. And you should keep in mind when I'm talking about some of the surgical approaches, especially for the laser ablation. In terms of the temporal lobe structures that we think about when we're talking about resective surgery, there's sort of four general parts. So there's the hippocampus, the amygdala, entorhinal cortex, and the parahippocampus. And what we call a formal temporal lobectomy addresses all parts of this. So you're taking out parts of the lateral temporal lobe. The mesial structures are those four that I talked about. Sort of the yellow and blue here. The yellow is kind of, if you're trying to be more selective and spare structures, those are the two that you try and address. Entorhinal cortex and parahippocampus are also mesial structures, but they tend to be, you can avoid those, especially if you're doing a laser ablation. In general, with surgery for epilepsy, the more brain you take out, the better chance the better chance you have of being seizure-free. So with a formal temporal lobectomy, you take out all four of these parts. You also take out some of the brain on the way to those targets. And you tend to get probably the best outcomes in terms of seizure freedom rates. So again, after about 2 years, about 65% are seizure-free. That rate does tend to drop if you look out further. And so there's a bit of a Kaplan-Meier sort of a Kaplan-Meier curve there. But 40 to 50% of people will still be seizure-free at 5 to 10 years, and it does tend to drop the further out you go. These data do include non-mesial temporal sclerosis, so if you just focused on mesial temporal sclerosis, the numbers would probably be higher. That said, it's still a lot better than 5%, which is what you get with medications. There are more selective surgeries, so different ways of trying to spare more brain can accomplish fairly similar outcomes. So the selective amygdala hippocampectomy, they call it that because you're just trying to get the amygdala and the hippocampus. The goal here is to spare the anterior temporal lobe, so you take less brain. There's some mixed data on whether or not this actually accomplishes the goal of having people think better afterwards. But people who do this tend to be pretty devoted to doing it. And, again, the thing with taking out brain is you can always take out more later. You can't put any back. So this is generally an approach that we use fairly commonly if we see evidence that most of the seizures are coming from just the mesial structures. The last thing that I'm going to talk about in terms of resection is the laser hippocampectomy. What this is basically is a thermal ablation. So you're using heat from the laser to kill the hippocampus and part of the amygdala. What this does is it does spare the anterior temporal lobe. It spares the lateral temporal and inferior temporal lobe. And this is a bit different from the selective technique, because the selective open technique, you still have to get to the amygdala and hippocampus through an open surgery. With the laser, the way it works is it's a catheter that you insert through, it's about a 2.5 millimeter hole in the back of the skull. and the laser catheter is straight, and I'll show you pictures of this, but you can basically avoid even cutting some of the white matter tracts that you can't avoid with the open surgery. This is just one of the first report of this technique. It's a small group of patients. Now we have reports of a couple hundred in our larger series. But for all comers, it was about a 50% seizure freedom rate just over a year. For mesial temporal sclerosis, it was about 2/3 of patients, and that's approaching the effectiveness of an open surgery. What's interesting is that people, if you fail this type of surgery, you usually see it early. The folks who continue to have seizures, you can usually tell pretty quickly. The reason this has been very exciting for surgeons is that, again, we do have more evidence that you spare cognitive function with this approach. Especially in the temporal lobe, the two sides of the brain do slightly different things, but recognizing objects is kind of considered to be a non-dominant function, so the right temporal lobe. Category-specific naming is a dominant lobe function. If you look at, again, in this series, they were just comparing two groups of patients, those who got open surgery versus a laser. The anterior temporal lobectomy patients, most of them had some deficits in one of these two categories, but none of the laser patients did. This preservation does tend to be seen. Okay, well, yeah, we're just scrolling through images here, and again, the yellow circle is just emphasizing that over on this side, the hippocampus, which is this structure here, it's very clearly different between the two sides. And again, these images are something that we use to help prognosticate whether or not laser ablation is a good idea. The way we do this procedure is under general anesthetic. We will place a stereotactic frame, or actually these days we use a robot, so you don't need the frame, but it doesn't make much of a difference. And what you're wanting to do is place the laser catheter along the line of the hippocampus. And this is just a schematic. They colored in the laser here blue. The hippocampus here is outlined in red. And so you're kind of targeting a curved round structure with a straight line, so there's a limit to how much of the hippocampus you can burn, but basically we do this, we double check our coordinates, our location in the MRI scanner, and use the MRI scanner to obtain a real-time temperature map. And so what the MRI can do is tell you how warm the brain is, and when you turn the laser on, it'll heat tissue that's right near the catheter. It's usually an oval shape, and you'll see this in real time here. What you see is we have a sense of what temperature in the brain is. We kind of blank it out, and when we turn the laser on, you can see the heat reading there. And the computer system also uses some algorithms to estimate when you've treated a certain part of the brain enough that it's essentially going to necrose over time. So basically whether or not you've killed that part of the brain. And so this little GIF here is just one part of the treatment. So you have this little circle here, and that's what the laser was able to reach, while the patients in the scanner will then just pull the catheter back a few millimeters at a time and repeat the burns until we're happy with what we see. And generally what you'll get is this lesion that looks like that. And so that was where the hippocampus was before. You can see this sort of bright circle. And basically that tells us that part of the brain is treated. Over time, you'll see these lesions just change slightly, but they eventually shrink down. And what you'll see is there's just no hippocampus on this side. The hippocampus on the other side looks normal. And again, the exciting part is that the rest of the brain out here, which with the open surgery you have to either cut through or you take out, you leave that alone. So the advantage of this is that it's minimally invasive. Again, the only hole in the skull, it's a 2.5 millimeter twist-drill burr hole. And so if you go looking to see where the laser catheter is, and afterwards patients, you really can't find it. You'll find the stitch where we close the skin, but that's it. The hospital stay is usually just overnight versus 3 to 4 days for an open surgery. There's less risk to this surgery, there's less pain, and it does work very well if you have a mesial temporal sclerosis. Over time, we found the open surgery still does work better. And again, I think this kind of goes back to the thought that if you take out more brain, there's less chance of that brain causing seizures. That said, the flip side is you do tend to have more cognitive side effects. Downside of this treatment is it is still fairly new, and so we don't have as much data in terms of how long seizure freedom lasts. And so comparing it to open temporal lobe surgery, we have 15, 20-year, 30-year experience with that in patients. Whereas with this, at the UW, we started doing this in 2013. So, 6 years is probably the longest we have. So next, I'm going to talk a bit about patients where you don't have this option, where using either a laser or open surgery. A couple reasons this might be the case. If you do have focal epilepsy, you may have multifocal, or you may have seizures that come from eloquent cortex. So the brain that you use to move your hand, brain that you use to talk, or if you have very poorly localized foci. So this could be either a large portion of abnormal brain or normal-looking brain, and it just looks like seizures come from more than one spot or a very large area. And at this point, we will think of neuromodulation. This is what we call a palliative therapy. So the goal is here to make people have fewer seizures or shorter seizures, and the goal isn't necessarily to be seizure-free. I mean, that's always the goal, but the likelihood of that is much lower. There's sort of three groups of therapies. There's vagal nerve stimulation, and the company doing this is Cyberonics. I guess they're leaving Nova now. RNS, which is responsive neurostimulation. That company is NeuroPace. And deep brain stimulation is sort of the newer, or at least the latest FDA-approved therapy. And the company with that is Medtronic. So I'm only going to talk about VNS briefly. It's been around the longest. About 60% of patients have half as many seizures over 2 to 4 years, and about 8% of people are seizure-free. These outcomes, it's kind of the same as if you had a fair to middling drug. So the efficacy of it is comparable to that. The nice thing about it is it tends not to be subject to honeymoon effects, and so if it tends to work, or if it works, it's going to tend to keep working. The advantages of vagus nerve stimulation is that we're not putting any instruments into the brain, and so to a certain extent it's less invasive. And you don't have to target a particular part of a seizure network. And so if you're having trouble figuring out where seizures are coming from, this can be a good option because to a certain extent you don't care where seizures are coming from. The device itself is two parts. One is an electrode that wraps around the vagus nerve, and the second is a generator. The stimulation works on a duty cycle, so it goes on for a few seconds and then off for a few minutes, and that's fairly standard. There's also a magnet that you can use to trigger the stimulation, but what it does is it sends electric current up the vagus nerve. The vagus nerve connects to a lot of different parts of the brain, and we don't know how it works, but it does tend to either reduce the number of seizures, make seizures last less long, and there's a fairly sizable population that this has been placed in. And so in terms of our experience with it, it's fairly extensive. I'm not going to talk about it too much, and apologies to the folks outside, but it's kind of boring. It just kind of, you put it in, you turn it on. They have an auto stim function that's added, and that's the new iteration of it. But it's just kind of it. So to me, I mean, I put these in, but it's kind of like prescribing a pill. And the other ones, the other types of neuromodulation are a bit more, I guess they're a bit more fiddly, which for me is more interesting. RNS stands for responsive neurostimulation. This therapy got FDA approval in 2013 for treatment of medically refractory focal seizures in adults. The device has basically two components. There's the electrodes, and you can have two different electrodes, and then the generator, which is actually implanted in the skull. And so the electrodes can either be what's called a cortical strip. So basically there's 4 electrical contacts there that can read signals from the surface of the brain. Or you can have a depth lead. So the depth lead is basically a wire that you pass into the brain, Probably the most common place you'd put this would be in the hippocampus. And there's 4 contacts on that. The device monitors electrocorticography, so voltage changes in the brain from either the strip or the depth electrode. There are embedded seizure detection algorithms on the device, and it'll trigger a burst of high-frequency stimulation to try to either prevent a seizure from spreading or to abort a seizure. This is what we call a closed-loop system. So what it does is it responds to data it's getting from the brain in real time. What's nice about this device is it also has a looped recording system. So if it detects a seizure, it'll record back a few seconds, and you get that data stored on the device, and basically you upload that to a computer. The company has a database with millions of seizures on record, and we can look back and use some of that data to analyze individual responses to that. And they obviously have other research programs looking at brainwaves and seizures and how to better treat them. But this is an example of downloaded data from a patient. And so at the blue arrow labeled 1, the patient says, "Hey, I'm having my aura." And you can see in this channel on the recording, brain activity changes a bit. And at B here, the computer's gotten enough data to say, oh, hey, this is a seizure. And so it does stimulation, and when it does that, it kind of blanks out the recording, because otherwise it would swamp the reading. But this brief stimulation actually doesn't do much. You can see that this is basically the seizure continuing. So the device realizes that, does another stimulation, and the brain waves go back to normal, and that's kind of where the seizure stops. So it's, again, doing this in real time, and some of our patients will have tens of thousands of these in a year that they don't notice necessarily because the machine has aborted them. In terms of long-term results from this, I'm going to go over data from one of the it's called the LTT, long-term treatment study. But this was an open label study, so people know that they were getting stimulation. The population was derived from both the initial randomized control trials or from the initial feasibility study, like is this going to work, versus the, hey, does this work better than other options? So it combined patients from those two groups and just tracked them over about 5 years. The number of patients was about 230, and some did drop out. So at the end, the results are from about 190 patients. What's interesting is there's kind of a fairly wide variety of patients who were enrolled. About half of them had more than one focus, so probably in this case, majority of them are going to be bitemporal seizures. So seizures coming from both temporal lobes, and that's not a population that we'd ever consider doing surgery in. And part of that is based on one patient, HM, from Canada, where they did do that, and he basically would not form new memories. So the movie Memento, if people have seen it, I guess the premise of that movie was it was a trauma causing bilateral hippocampal damage. But you can put this device into both hippocampi and treat that type of epilepsy. The other types of patients were kind of mixed. So neocortical, meaning just different parts of the brain that were not mesial temporal lobe, and about a third of them had previous VNS implants. So, sort of bottom line, about 2/3 of people have about 2/3 less seizures, which, frankly, is fairly similar to VNS in terms of just final outcomes. But there are some other things about this that are interesting. In terms of bad things that happen, infection is kind of the most common thing. Of this 9, approximately 10% of patients, only half of them actually needed surgery to take them out because of the infection. And 5.5% it's a little high for implants. I do a lot of implants for other reasons. And that's kind of 5.5%, it's kind of just at the high range of what we would expect. There are some patients who do worse, and that's probably going to be true about any of these neuromodulatory therapies that we talk about. But what is interesting is that in this long-term analysis, we did see that people seem to continue to get better. And some of this may be because you can tweak the algorithms to detect seizures and provide stimulation. And so over up to about 8 years, you see this sort of gradual increase in people who have better and better seizure control. Another measure that they looked at was improvement of quality of life measures. In about 5 years, just a little bit under half the patients had significant improvements in their quality of life. And so even though they weren't seizure-free, they did tend to do better. In terms of neuropsych and cognitive outcomes, just in terms of groups, there wasn't really a decline. If you look at specific tests, and again, we're looking a lot at sort of temporal lobe type cognitive things because we're good at figuring that stuff out. The patients who had neocortical epilepsy improved on Boston naming. With mesial, they improved on the Ray Vault. But basically what this differential effect is interesting because those are the things that you would expect to get worse if you'd taken that part of the brain out. And so what this implies, and again, this is pretty early and we don't have a ton of data, is that this can spare some of the cognition that you would otherwise worry about if you were doing an ablative or a resective surgery. The last thing I'm going to talk about is deep brain stimulation. This was approved just last year as an adjunct therapy to reduce seizure frequency, again, for partial seizures that you can localize. And the specific target that they approved was the anterior nucleus of the thalamus. DBS is usually a therapy that we think of for movement disorders. So people with Parkinson's or essential tremor, we know it works better than medicine. We've been putting them in the US since the 1990s. There's tens of thousands of folks walking around with them. It works really well for that. For seizures, the data's not quite as good, but I'll get to that. But the system involves sort of a maximum of 2 electrodes, again with 4 contacts each. The generator for this is in the chest, but you basically implant the wires, run a lead extension down to the chest. And this provides what we call open loop stimulation. So it's tonic, meaning it's always on. In terms of where people put these electrodes, again, the FDA approval is for anterior nucleus, but because neurosurgeons are neurosurgeons, we've put them in the hippocampus, in the central median nucleus, in the STN, cerebellum. There's varying justifications for all of these places. But again, that does make it a little bit more interesting in terms of potentially targeting different types of seizure networks. The main trial that most of the data supporting this comes from is the Sante trial. And I'm looking at data, I'm showing data here from sort of the extension of the trial, so not the original randomized control study. Initially, about 160 people said yes, they'd like to do it. In terms of long-term follow-up, there's only 75, which sounds really bad, but 50 of them initially were not, either didn't meet criteria for implant or withdrew their consent. But it's still about a 25% drop-off over the years. The patient population is 18 to 65 with refractory partial epilepsy, and you've had to have tried 3 drugs. The main outcome measure they were tracking was seizure frequency, so how often you have seizures, and they were only tracking it by diary, which if you don't have another way of, so the responses are RNS, it's nice because you can actually see how many seizures somebody has from the device itself, but the DBS doesn't have the capability for that quite yet. Bottom line, over time, this also does seem to do better. And after about 5 years, people, the seizure reduction, significant reduction rate was about 69%. So again, significant reduction is half as many seizures. And there just is this general trend towards more people reaching that point over time. And they did keep track of things like, is this just because people where it didn't work, they dropped out of the study? They did account for that, which is good. Again, most of the patients, there's a good mix of patients again, so in terms of whether seizures are from the temporal lobe or frontal lobe, but we did see sort of different response rates. So temporal lobe epilepsy seemed to get better at a greater rate than seizures from other places. A lot of these patients had previous vagal nerve stimulator. Again, this didn't seem to make a difference, so it wasn't like this added to VNS. And in terms of quality of life improvement, about half the people had a significant improvement. So again, even if they didn't get seizure-free, there did seem to be an improvement in how they did day to day. This funny-looking graph here just the individual seizure response rates. So there's a sizable portion of people who did worse. About 3% had more than a 50% increase in seizures from this. That said, the vast majority had decreases. And again, at sort of 5 years, is about a 69% reduction. About 20% of people didn't have any more seizures, which is a little bit higher than for RNS or VNS. In terms of side effects, the biggest one is pain and discomfort, which they tracked in this study. I'm sure the numbers are about the same for the others. The infection rate was about, again, about 12%. And again, only about half of those folks actually needed the device taken out. So that's probably on par with other indications. Other types of hardware malfunction was another 10%. So these wires, it's a little bit longer compared to the RNS, which is just in the skull. You have to run the wires down to the chest, and so there's more opportunity for those to break. And in terms of cognitive outcomes, it's interesting that on a subjective level, there's a sizable number of folks who thought that their mood was worse, that their memory was worse. If you look at the objective testing from neuropsych evaluation, that didn't really get borne out. So there weren't any significant declines and a couple of significant improvements. But again, if you feel like you did worse, that's kind of about the same thing as if you did do worse. So again, I think for any of these treatments, and this includes surgery for epilepsy, if you go through all this trouble and you don't get seizure-free, everything's terrible. So that said, again, the majority of people do seem to do a bit better. So overall, in terms of neuromodulation, we think of this as a palliative therapy. So we're not telling people this is going to make you seizure-free. What we're aiming for is half as many seizures, some improvement in quality of life. In terms of different types of treatments, 60 to 69% success rate. So I usually will just say 2/3 of people have half as many seizures. It's very uncommon to be seizure-free. The one thing that's better than drugs is that the improvements seem to be durable and that maybe they get better with time. And so you don't have that honeymoon period where you seem to do better for a while and then it stops being effective. The downsides to this mainly seem to have to do with hardware infection, so about 10% there. Hardware failures or revisions, so wires breaking, wires not being in the right place, about 10%. And probably 5 to 10% of people are worse. And the last... The thing is, unlike resective surgeries, if you are worse with these therapies, you can turn it off, you can take it out. And so to a certain degree, that's reversible. And then the last thing is that these devices all require maintenance. So the battery life, depending on how much stimulation you're doing, it ranges from 3 to 8 years, depending on the device. In terms of comparing the two surgeries I talked about in depth, so DBS is a tonic therapy, so it's just always on. What you're trying to do is target an epilepsy network in the brain, and so these parts of the thalamus, the subthalamic nucleus, central median nucleus, these are sort of hubs where parts of the, when seizures spread to other parts of the brain, so when they generalize or cause convulsions, what you're hoping is to block that spread. We do see some evidence that neuropsych tends to improve with this. Most of that improvement's in executive function, so I'm not sure if it's just people sleep better, but it's kind of frontal lobe stuff. And the difference between these two is that the DBS implant is in the chest. For responsive stimulation, obviously it's responsive to patient states. It does store data, which can be useful in terms of giving your neurologist a bit more information about where your seizures are coming from, where they're going. The therapy for this is local in the brain, and so you have to have an area that we as surgeons feel like we can cover with the electrodes. So if there's a large part of the brain that's causing epilepsy, we're not going to probably be able to cover it with electrodes. Again, there's some data that cognitive outcomes might improve, or they certainly aren't worse. And the implant's all up in the skull, so you have one incision on your head. In terms of things that, again, why I consider these two more interesting than VNS, at least at this point, is that for DBS there are multiple targets and hence potentially multiple networks, and so looking at connection patterns in the brain might help guide better placement and potentially better results based on where your epilepsy is coming from. DBS does have sensing capability, they just haven't incorporated the the epilepsy part of it. And so that's something that might be in the future as well. And then all of these stimulation devices right now, they're just kind of on or off. There are a few parameters that you can change, but they're all a very basic square wave form. And there's other ways to do stimulation that people are looking into. Same thing with RNS, looking at connectivity. So right now, again, we worry if there's a large area involved, how can you cover it with electrodes? We may find that smaller parts of this large area are actually more important, and so if we can find those areas, we can target that and not worry about some of the other larger parts of the abnormality, and find more people to potentially implant this in. Eventually, they are going to increase the number of electrodes that they can place for this type of responsive stimulation. And again, right now we're doing basically it's like a high frequency stimulation that's supposed to mimic blocking brain signals, and there's other ways of doing that. Last thing, again, just to reiterate, none of this is in the pediatric population. So these are adults 18 to 65 for all of these. Not to say people don't implant these for children, but that's a little off indication.
These last ones you're talking about,
Yeah.
are folks now off medication when they're on those? So I'm just trying to figure out folks that have gotten worse. Is some of that because the procedure's not working and they're now off medication that might have been partially working? I'm just trying to figure that out.
Oh, I'd say most people would stay on medications with these therapies.
Okay.
And so this is a lot of these neuromodulations. I tell people to think of it as like adding another drug that works slightly differently and potentially better.
Thank you.
And I think thinking of these treatments like a drug is kind of helpful because, again, it can take some time to kick in. So same with medicines. You usually don't take a pill and then suddenly the next day everything's better. There are side effects to this. There's side effects to medications. These you can turn off. And so if you do know that you're worse, you can turn it off. Telling whether something's making you better or worse is always hard, right? I mean, it takes some time. So that figures into it too, but it's not because people usually get off medications.
Thank you.
Yeah. Sure.
I was just going to ask, is it painful? Can people feel it?
Usually, you don't feel the stimulation. So when you get programmed for these, or so for RNS, usually they're in spots where you're not going to feel it. For the DBS, during programming, that's something that you test. So you turn on the stimulation, you turn it up as fairly high and see if people feel anything. But during therapy, it's not something you feel. It's a little bit different from vagal nerve stimulation.
With the
I could probably add to that too. When we program our RNS folks, we test it during the programming.
Yep.
And if they're feeling something that's uncomfortable, we'll turn it down. There are some programming strategies where we'll actually leave the very last stimulation set slightly higher so that they do have a tendency to notice it in case they want to sit down or get ready for something that is perhaps going to be bigger and more scary. But most of the time, like Dr. Coe said, we don't want them knowing that they're getting stimulated because they're getting stimulations up to 1,000 or 2,000 or 3,000 times a day.
Yeah, one of our patients, he has like 10,000 triggers in a day, and that's almost like always on, right? But not all the time, but so yeah, the programming part of the RNS, especially sometimes if you're putting it over motor cortex or sensory, you do have to be careful about that. But I'd say during the programming, you're looking for things like that, so you're trying to make it give you a side effect that you can detect, so that you know to avoid it.
Thank you. Last year, the FDA put out an alert for the laser ablation. Has that been basically cleared?
Which alert? They've placed several for different things. A lot of them come from us, actually. With the laser ablation, I think you said last Tuesday or last year. Last year. Oh, so last year, yeah, the last year one. I was going to say I'm not sure where the Tuesday one, but last year the alert they put out had to do with the fact that there are with the MR thermography. So when you're using the MRI to detect temperature, we call it real time, but there's a sampling rate, And so it's either every 3, every 6, or every 9 seconds. So the image refresh rate takes some time. There's a couple of things about this that we've learned over the years is that one, the MRI like baseline setting can change. And so if that's drifting around and you're not paying attention to it, you might think, oh, well, it's 40 degrees and it's actually 45. And 40 to 45 is kind of, 40 is okay, 45, you're borderline okay, 50 degrees, 60 degrees, you start to see brain die. So just keeping track of the temperature, it was what the FDA alert was about. Any of us who do this often were not surprised by any of this, and so it lagged by 3-4 years in terms of what we were doing to address those issues. I mean, if you want to know the trick, there's tricks around all of these things, but bottom line is, it's to keep in mind that it takes, if you're looking at 2 angles at your laser, it takes 6 seconds before you get your data, and so we usually just have to bear in mind when the laser's on and it's refreshing and giving you that picture, you're lagging a little bit. So.
All right, we're going to stop there. I know there's some additional questions, but Dr. Coe might be able to hang around for a little bit and take some more questions.
Sure.
Thank you, Dr. Coe.
Yeah, thanks for having me.